Hello, I'm Dr. Hisham Salahuddin. In today's SVINutes, we will explore the management of tandem occlusions, a complex and evolving area in acute stroke management. Tandem occlusions involve severe stenosis or occlusion of an extracranial vessel, typically the cervical internal carotid artery, accompanied by an intracranial occlusion. This dual occlusion presents unique challenges in both medical and neuroendovascular treatment. Tandem occlusions are often associated with a high clot burden, particularly if the extracranial lesion is occluded. Many questions remain about the optimal management of tandem occlusions, as no randomized studies have specifically addressed this group. Data only exists from multi-center registries and meta-analysis. Key questions include the role of intravenous thrombolysis, endovascular approach to extra or intracranial recanalization first, the use of acute angioplasty or stenting, and post-procedural antiplatelet regimens. Clinical trials have shown that adding IV thrombolysis to mechanical thrombectomy is not non-inferior to MT alone. However, given the large clot burden and frequent post-procedural antiplatelet needs, some question its routine use in tandem occlusions. A pooled analysis of the Titan and ETIS registries demonstrated improved recanalization and functional outcomes without an increase in symptomatic ICH with IV thrombolysis in this setting. A meta-analysis of over 1,800 patients across 9 studies also supports its use. Administration of IV thrombolysis for tandem occlusions is safe and effective. Neuroendovascular treatment can involve an extracranial first or antegrade approach, addressing the proximal lesion first, or an intracranial first or retrograde approach, targeting the distal occlusion first. Endovascular approach is often influenced by occlusion etiology, degree of stenosis, and operator preference and experience. An intracranial first or retrograde approach may result in faster recanalization times, and data from a German observational registry, along with a meta-analysis by Zevelos and colleagues, suggests that this could lead to improved clinical outcomes. While acute stenting for tandem occlusions requires post-procedural antithrombotics, the rates of symptomatic hemorrhage are comparable to those in patients who do not undergo stenting. Acute stenting has demonstrated better clinical outcomes than angioplasty alone in 2 large multi-center studies with over 600 patients each, as well as in a meta-analysis of nearly 6,400 patients. However, the effectiveness of stenting may be influenced by the underlying proximal etiology, whether due to carotid atherosclerosis or dissection. Following intervention, acute antiplatelet therapy is essential to prevent reocclusion. Approaches vary widely, as revealed from a survey of 209 neurointerventionalists with diverse training backgrounds. Some practitioners prefer dual antiplatelet therapy to mitigate immediate thrombotic risks, while others choose a single agent based on bleeding risk. The optimal antiplatelet protocol remains an area of active investigation. While we've made significant progress, important questions remain. Ongoing research, including trials such as the Picasso, Titan, and Eastside Talk, will help answer these questions and refine our treatment algorithms. In summary, tandem occlusion management is multifaceted. Advances in research continue to shape best practices, helping to optimize outcomes in this challenging patient population. Both IV thrombolysis and acute stenting appear to be safe and effective. Both antegrade or retrograde approaches are viable, though an intracranial first approach may offer greater benefit. Data is currently insufficient to support a specific antiplatelet regimen. Thank you for joining this discussion on tandem occlusions.